Good morning, everybody. I hope you can hear me out there. Thank you very much. Thank you very much indeed for joining us this morning. Good morning. I hope everybody is well. And I am Kathy Smith. I'm going to be your moderator this morning. Everybody, of course, is talking about COVID-19, quite rightly so, but we mustn't forget that there are other diseases out there. And we're talking today about cardiovascular disease. It is actually the #1 killer in Europe. It is the #1 killer in the world. And of course, people with cardiovascular disease are much more vulnerable when it comes to COVID. It's a big issue. So the question that we're asking today is how to turn around the increasing burden of cardiovascular disease in Europe. So we've got a panel of voices. We've got patients, we have got healthcare professionals, we've got policymakers, academics, industry, and we've got you. So we want to hear from our panel. Of course, we're going to have a great conversation, but we also want to hear your questions. You'll see that there is a Q&A function at the bottom. I'm sure everybody knows how to use these now. Can I just ask that you don't use the chat function for your questions, because that might get a bit confusing for me because I'm not necessarily looking that way. And we'll keep the chat function just for anyone who has any connection issues. So do put your questions though in the Q&A. And tweet, we want you to tweet. We want to get the conversation going. So it's hashtag questions inspire solutions. So we need to get talking. So the event, as you know, is co-hosted by FPA and the European Heart Network, and Birgit Beger is the CEO of the European Heart Network, and she is joining us now. I hope, Birgit, that you are there. Lovely to see you this morning. So tell us, I already mentioned that cardiovascular is such a big issue worldwide. In fact, it's the biggest killer. Give me some facts and figures on a European scale.
Yeah, good morning, Kathy. Good morning, everyone. Nice to meet you there and join you and discuss an important topic close to my heart, as I can say. And numbers and figures, they're cruel, I say. So we have 60 million people in the EU living with cardiovascular disease and 30 million new cases. It's a chronic condition, and it leads actually to costs. It's an economic burden as well. So we speak of 210 billion euros per year, and that's 111 healthcare costs in billions, and then 54 billions in productivity loss, so the participation in the work life, and then 45 billion in the informal care costs, so that after hospital. So it is a very widespread and expensive disease not to be taken care of properly.
And quite clearly, the COVID situation cannot have helped. It must.
No, Casey. It's terrible because people with this precondition, they get worse through COVID. They suffer more. They are more likely to get infected. But we also see people who haven't been affected by cardiovascular diseases. They get COVID, but afterwards they had heart inflammations, they have heart muscles problems. So they end up with cardiovascular disease as well. So that makes COVID a very dangerous disease for people already touched by CVD.
And cardiovascular disease as such, they don't seem to be very high on the political agenda. I mean, we know, for instance, at European level, that cancer is very much at the forefront, and so it should be. I'm not suggesting it shouldn't be, but we don't hear so much about cardiovascular disease.
Yeah, that's surprising because 36% of all deaths are due to cardiovascular disease. So it is something we should really look at. But I have the impression, as you say, it's a bit forgotten. And I'm new in the cardiovascular disease area, so I'm rather surprised about this lack of attention which the healthcare system pays not to it. And I think there is a lot to do, and we have interesting developments. We have the EU for Health budget. We look into the resilience of the healthcare system, because that's what we need to tackle. We need to get people with CVD early detected and also treated in order to avoid that it degrades. And then there's also very interesting, just at the end of November, 25th of November, the new EU pharma strategy. And I was looking there, maybe they got the COVID inspiration, maybe there's something in it, but I didn't find among the unmet needs where I was looking, because from my perspective, CVD is an unmet need, but I didn't find anything there, though we should definitely see how we can collaborate better to have a more concerted action in order to address CVD at a European level.
Well, so what do we need to talk about today then? Our panelists are standing by.
So we need to talk of course, prevention is always better than cure. That's what we start with, but we can't stop here. We need to look at innovation. We need investment in research. We need to improve in digitalization, so to connect the GP, the general practitioner, with the hospital practitioner, and then also the social care, so that we have the CVD patient all enshrined in through the whole pathway. Then, of course, we need also research for new medication, definitely. And I think what is also very interesting is registries. We want better if we know more. And in order to this, we have to connect the specialists, and we have to have the data connected in order to have also targeted policy action and legislative action, because we know facts and figures. So that I think there's plenty to do. And EHN has already outlined in a blueprint for EU action what are the steps to take. And I think one idea is, because we talk cancer and it is important, but we also see that cancer treatment affects CVD patients much more gravely. So we should look into include CVD condition when we are talking and researching cancer. So that was my little idea already as a start.
Right. Okay. Well, you're going to join us at the end to give us some of your thoughts. So let me introduce our panelists, and let's see what of those points that we can bring out. So let me introduce our panelists. If you'd all like to put your cameras and microphones on, please, hiding away. There you are. Let me introduce Panos Kanavos. He's Associate Professor of International Health Policy at London School of Economics and Political Science, an expert in the economics of medical technologies and access to medical technology. So morning to you. We have Mariana Taki. She's still, I think, hiding, and we're not seeing her yet, but Mariana Taki is Policy Coordinator of DG Sante, there you are, at the European Commission. I know that you're a public health doctor and responsible for developing the EU policy on non-communicable diseases. So, welcome to you. Janneke van der Kamp is Head of Pharma Region Europe of Novartis. She's Dutch and she's a chemist by background. Hi, Janneke. Patricia Vlasman, former political scientist, but now working as a patient representative for cardiomyopathy research in the Netherlands. And Patricia was born with congenital heart disease, suffered heart failure, and had a subsequent heart transplant in 2018, and has written a book about it, which I think sounds rather interesting. I'll have to ask you some more about that, Patricia, afterwards. Matt Whitty joined us. He's the Interim Director for Innovation Research and Life Sciences at NHS England and NHS Improvement, and also the interim chief executive of the Accelerated Access Collaborative. You can tell us more about that, Matt, when we come to talk to you. And Professor David Wood, cardiologist, past president of the World Heart Federation, holds joint emeritus academic appointments at Imperial College in the UK and also the National University of Ireland, Galway. So that is our panel. Lots of people, but all very taking different perspectives on our conversation. So welcome to you all. I want to start looking at the challenges. We won't dwell on them too much. We know they're big, and then we want to look at solutions. And I think that's what our conversation really needs to focus around. But if we're talking about challenges and where the unmet needs are still, perhaps David Wood, you'd like to come in on this and give us a sort of sense, because there have been huge there has been huge progress in treatments, but there are still unmet needs.
Yes, thank you, Kathy. I mean, cardiovascular disease, heart attacks and strokes is fundamentally a political issue, which is all the more surprising that it's not prioritized by the European Commission. And as Birgit said, it's the commonest cause of death, importantly, premature deaths. And most importantly of all, it is preventable. We know the causes of atherosclerotic cardiovascular disease. and the priority should be prevention. And that can be addressed at 3 levels. And we should start with the sick, those who present to our hospitals with heart attacks and strokes, and care in terms of the technological advances, angioplasty, stenting, the therapeutics that we now use in terms of cardioprotective medications have really transformed the management of this disease and really reduced case fatality. And there is a great deal more that we can do for these patients in terms of secondary prevention, although that is poorly implemented in many parts of Europe. But it's not sufficient just to look at patients coming into our hospitals, because actually many don't get to our hospitals because they die suddenly and unexpectedly in the community. And therefore we need to think about primary prevention as well. And that means population-wide screening of the adult population in order to detect those individuals at particularly high risk of developing cardiovascular disease. And they then require appropriate lifestyle support and treatment of risk factors like blood pressure and lipids, diabetes, and so on, in order to reduce their cardiovascular risk. And secondary prevention is not as well practiced as it should be, but primary prevention falls a long way behind that. And as you remarked at the beginning, COVID-19 has really exposed our unhealthy population, because those with cardiovascular disease and at high risk, particularly the obese and those with diabetes and hypertension, have suffered disproportionately in terms of mortality from COVID-19. In fact, cardiovascular disease has suffered a double whammy, because many people have not come forward with their acute symptoms and therefore have not benefited from our treatments.
Sorry to interrupt. Let me just bring Patricia in from the patient's perspective. I mean, you heard there David saying that it's a political issue, but what are your observations about why cardiovascular disease is not as high on the political agenda as so many people would like it to be? And also your observations, what you've seen in terms of the impact of COVID.
Well, Kathy, I think the reason why cardiovascular disease is not #1 on the policy agenda is because it's not a visible disease. In case of cancer, everybody sees that somebody is suffering from a major disease. And in cardiovascular disease or heart failure, it's not visible from the outside. So never judge a book by its cover, you know. And about COVID, well, if I look at the situation in the Netherlands, we have 1.4 million people before COVID suffering from cardiovascular disease. And well, I'm really holding my heart about the future. And I totally agree with Birgit that we have to invest in early detection, and that needs funding for research, especially also the congenital heart diseases. We don't have if you pick around 20 people from the street, I can assure you that 2 people of them absolutely will have a congenital heart disease, but they don't know it. And it will expose later on in life. And then you have to, those people cannot work, they cannot, they cannot contribute. So we have to really detect earlier by invest in good research for early detection.
Thank you. Let me bring Panos in now. If we're talking about, we've seen the strain on health services that COVID has brought about it, but if we want to have sustainable and resilient health services, how important is it to really be able to tackle cardiovascular disease?
Kathy, I think it is very important. It's crucial. I think you talked about the cardiovascular mortality and ischemic heart disease and stroke being 2 of the leading causes of mortality in high income, upper middle income and lower middle income countries. And I think As far as the healthcare systems are concerned, this poses a significant health and a fiscal burden on healthcare systems. And they have to manage in this particular context. Now, if we're looking at healthcare systems, I think they suffer from what I call disruption-prone characteristics. And I think that influences the way sustainable care is delivered. For example, sometimes we treat too late. Oftentimes we treat all the same, in other words, without personalization. Very frequently, we offer variable care quality. Most frequently, we do not necessarily coordinate care. And equally frequently, patients ignore our advice. So we have a significant issue of non-adherence to treatment. That leads to another observation, which I think is important to bring to the discussion here. In most developed countries, as much as 2/3 or close to 70% of all healthcare expenditure is spent on 5 to 10% of patients. And that, of course, includes cardiovascular disease patients. And these 5–10% of patients, including cardiovascular disease patients, is a high need, obviously high risk and high cost group characterized by high prevalence of chronic disease and multimorbidities and complicating factors. So therefore, the objective here would be to try as much as possible to offer coordinated care, improve adherence, improve health outcomes, and optimize on costs wherever possible. So therefore, the focus of efforts on patients with highest risk therefore requires, from a healthcare system perspective, a four-part strategy in order to continue delivering care in a sustainable manner as part of a universal health insurance coverage healthcare system. First of all, we need integrated care systems. Secondly, we need primary care and delivery system reform. And I think David alluded to that earlier on. Perhaps we do need payment reform, and that means the kind of incentive structures that we have in place for primary and secondary care providers. And thirdly, a health information, sort of an integrated health information technology that links different components of the healthcare system. Now, all that are capital and relate not only obviously to cardiovascular disease, but the totality of the patient population. If we do that, then we are probably going to have an opportunity to offer sustainable care for our patients, but not one thing, but all of these things together.
Let me, well, we're obviously going to discuss that whole integrated care a little bit later in a moment. I just want to first of all ask, from the pharmaceutical point of view, if we're talking about where, from the industry point of view, if we're talking about where there are gaps, where there are still problems, what would you say, Janneke, needs to be dealt with?
No, so I definitely agree with all the previous speakers that for a big proportion of the unmet medical need, there are already great treatments and treatment options available, but they're just not getting to the right patients at the right time. Having said that, of course, there still are unmet medical needs that require new innovative solutions, new research. And obviously that's where the core role of the pharma industry is, and where the industry is highly committed to help deliver these new innovations. I have to say, though, that it's not easy to innovate in cardiovascular risk. The trials that you need to prove outcomes, which is what payers ask for, tend to be very long, multiple years, and tend to be with tens of thousands of patients. So this is not as easy as developing a COVID vaccine and testing in a few months. This is multiple years and multiple tens of thousands of patients to develop new medications. But obviously, that is the core role of the pharma industry that everybody expects us to play and that we are playing. But we definitely also want to play and are playing a role in everything else that was just highlighted by previous speakers in terms of the acceleration of the patient journeys.
Right. Well, let's get a little bit more now into what we can do. We've heard that it's a political issue. So, Mariana, let me bring you in, and then obviously, Matt, don't worry, I am coming to you, but I want to ask you what you're doing in the UK. But let me just bring Mariana first, because we heard that it's a political issue. We heard that Birgit talking about surprise, for instance, that there wasn't more mention or any mention much in the pharmaceutical strategy, for instance. What is the approach at EU level to this disease?
Yes, thank you, and good morning, everyone. Do you hear me well?
We
I
hear
changed
you.
the system.
We hear you perfectly.
Okay.
Perfectly.
Okay. So, so many things so fast you already touched upon. Maybe I could start with the fact what is our limitations, because the treaty, of course, the Article 168 sets out what the European Union can do in the area of health. So in terms of public health, health systems is really something where we don't have a role. We coordinate or support member states' efforts, but they are responsible for the health systems. So from the public health perspective, I've been working in public health 15 years now in the Commission. And I think the core and has been always and will continue to be health promotion and disease prevention. And in terms of health systems, what colleagues in Brussels are doing, they are trying to support member states, especially now after COVID-19, when the European semester has revealed also lots of concerns by the member states. I think it's over 20 member states who have country-specific recommendations related to health systems. And so the role of the Commission is a little bit more limited than what the situation would now actually require, what could be done. Of course, we don't know about the future, but that's the starting place. And then the second thing I wanted to say is that of course, we've been doing lots of things over the years. We funded lots of projects through different programs, not only health program, but also other funding programs on health. And in the past, before I came to this unit, I think there were around 15 different expert groups on different conditions or diseases. We had mental health, we had dementia, we had rare diseases, we had patient safety, we had lots of individual condition expert groups, and those expert groups worked in silos. There was not clear coordination, and what's more important, there was not really a mechanism to take forward the work of the expert groups. So what we've done now since 2018, we've turned this around. We went to the member states who are the ones who have to implement recommendations or actions also coming from this COVID-19 crisis now. I mean, I've never seen so many Commission communications and Council recommendations coming out than now in this COVID-19 situation. But it's the member states who have to implement. So we went to the member states and we said, what is it that you really need? And then we looked at the existing material, best practices, projects. And from there, I can say that already in the first years of this strategic framework, it's a steering group on promotion and prevention, the member states prioritize cardiovascular diseases. And we have set up, but this is really about health promotion, disease prevention, not about secondary prevention, more about primary. So we have a joint action on nutrition, focusing on childhood obesity. We have project on GPs prescribing physical activity instead of drugs to patients who have, for example, pre-diabetes or diabetes. We have a project called Young 50. It was a Cardio 50. I think it came from Italy, and the idea was to screen 50 plus men risk group for cardiovascular problems. So it's not that cardiovascular diseases as such would not be a priority at the EU level. I think it's been throughout the work we've done on public health, but more and more we are trying to focus on horizontal actions, and we focus on risk factors, because you can imagine we cannot go back to disease-specific approach. And maybe finally I could just mention that I know that it could be worrisome for some people that cancer has such a priority now, but really this is the first time health is ever this high on the agenda of the EU. And I think what we should do, instead of thinking that could we have further and further initiatives, of course there will be more money, hopefully, from the EU for Health program, but we need to hook and we need to find sort of common synergies and then try to push other issues or priorities through the cancer initiative as well.
But I mean, when you say that you can't be disease specific, one understands you can't deal with every single disease, but we are talking about the biggest killer in Europe here. So, you know, you have got cancer out there, and the name of cancer is there out front. Surely cardiovascular would actually fall into a category of its own in that sense.
Well, it is a priority. Member states have said it's a priority. And for example, now within the steering group, we carried out a survey for priorities. So each member state, actually, they just ranked what are the key priorities for the work, for best practice collection, project initiatives, actions, whatever we can do. And the list was very clear. The number one was AMR, and second one was cancer. Third one was availability and access to medicines. And the fourth one was NCD prevention, linking with the risk factors. So I don't think cardiovascular diseases as such is not a priority. On the contrary, it has been and it will continue to be, but it's just the methods are a little bit different. We have the major cancer initiative, we have the cancer action plan by DG Sante, and then we have from RTD the cancer mission. And together, these are of course a very powerful element, but this is politics, why it came to the agenda. I'm just saying that instead of thinking why not, it's rather to think how can we get into that, how can we integrate into the actions there? Because I think it's a benefit for everything. I've never seen, I don't know if anybody has ever seen such a push for health in the EU, and it's really now the momentum we have. I mean, it seems like I'm alone in the office, but there are lots of people working on these issues behind me.
Absolutely, and I think we'll talk some more about all those opportunities. Let me just bring Matt Whitty in now, because we've heard about the importance, certainly from Panos and also there from Mariana, about this integrated approach to health issues. Tell us what's happening in terms of the National Health Service in the UK and its approach to cardiovascular.
Thanks, Kathy. So certainly from an NHS perspective, prevention of cardiovascular disease is an extremely high priority. So it featured extremely prominently in the NHS long-term plan that was published last year, and it was recognised as the largest cause of premature mortality in deprived areas, and the single biggest area where the NHS can save lives over the next 10 years. So certainly from an NHS perspective, it is extremely high priority. There's a range of things that we're working on to prevent that. So we're looking at how we can get better at early detection and early intervention for patients with risk of cardiovascular disease. So really focusing on detection of atrial fibrillation, blood pressure management and cholesterol management. Close working in a more integrated way, as you were alluding to, so working with partners in local government and also Public Health England to implement more effective approaches to identifying and risk stratifying these patients. So particularly through something called the NHS Health Check. And again, we're seeing a lot of these as community interventions, so linking into the earlier point made about this being a community and more of a population health problem rather than a secondary care problem. And we're also looking to undertake more audits of patients in primary care. So we've got a programme looking at cardiovascular disease audits in primary care, and also looking at more investment in cardiovascular rehabilitation as well, and looking at sort of rehabilitation of patients to prevent that secondary prevention. So extremely high priority.
And are we seeing, in terms of the financing of this, is this public money or is it public-private partnerships? How is it working?
So the interventions that I was describing, this is publicly funded, but there's also legislative change that we're looking at as well to better support more integrated approaches to care. So the NHS England and NHS Improvement Board met last week and looked at and agreed a support programme for moving integrated care systems onto a firmer legislative footing. So we've got sort of a number of sort of pilot sites that are looking at different models of integrated care. But there's now support for formal legislative change to embed those long term.
Thank you. So, David Wood, when you, I mean, you must be familiar with what's happening that Matt's just describing, but how do you see sort of new models that could actually be created in different countries that could really make a difference in terms of the outcomes for cardiovascular disease?
Well, I think that's a very interesting question, and Matt has summarized very well the initiatives being taken in England to address prevention. I'm currently working in the Republic of Ireland on the west coast, and Ireland has embarked upon a completely new way of delivering care. I call it the third way. So not hospital-based care, not care through general practice, but through community hubs, which are being created around the country, led by nurses leading interdisciplinary teams, dietitians, physiotherapists, pharmacists, and so on, addressing both secondary and primary prevention of cardiovascular disease, including the management of diabetes. So these community hubs are really the center for lifestyle intervention led by health professionals whose knowledge and experience and skills is appropriate to the topic of prevention. So it's a new and imaginative way of thinking, yet to be evaluated, but abandoning the traditional hospital and primary care model.
And what do you make of what Mariana was talking about in terms of policy, the fact of looking at cardiovascular disease in a more sort of horizontal way, if you like, not saying we are just having a campaign for this disease, but approaching it in prevention at different levels. What do you think, David? Do you think that is that the right approach, or do you need to actually have the name of the disease up front and in people's minds?
Well, I understand the rationale very clearly, and we're really talking about the common determinants of non-communicable diseases. But NCDs is a term I absolutely hate. I have never diagnosed a patient with an NCD. A patient has had a heart attack or a stroke, or they have diabetes or whatever. And so there is something to be said for giving a name to the diseases that people carry in their everyday lives. It has more meaning. And the fact that the European Commission flagged up cancer is an important signal to countries, even though healthcare delivery is the responsibility of national governments. And I think the same signal should be there from the Commission in relation to cardiovascular disease.
And let me bring Mariana in then, and then I want to bring Patricia in and ask about the patient's role. But what do you think? How would you respond to that, Mariana?
What do I respond to all of these questions? I think, no, I'm a medical doctor myself. I have treated patients. I know what you're talking about here. But at the same time, we're talking about the whole European Union. And in the past, if you look at what the money we had to invest in projects, we had about 50-60 million euros per year in the past to cover everything, everybody wanted us to cover, including member states. Now we are talking about a different thing. I think the EU4Health program, it's a kind of a game changer. It's not as big as we thought in the spring, but still it's, a multitude of what we ever had. And I think the opportunities can come from there. We had to reduce the amount of things we can do in the past because of the money, but also the fact that I think the health systems are now going to go through major reforms. I mean, this will have to happen. That's the next phase of the recovery of the pandemic. And even though the EU4Health program is one tool, there are other financial instruments. And I'm in the unit which is responsible for health promotion, disease prevention, and financial instruments. And I think that's quite important to note that we can do a lot more, I think, in the future in terms of funding. But the next problem will be then how we ensure the synergies. So instead of doing this and that here and there, we have to have coherent plans and joint objectives, what we try to achieve. And for us and for the member states, the guiding framework, so to say, is first of all the WHO's NCD targets. And I know that NCDs is a funny name, but it's better than chronic diseases. If you have to choose between NCDs or chronic diseases, I use NCDs. And also the Sustainable Development Goals. So we have higher level targets that we try to achieve, and we support the member states. And I think there will be also funding opportunities from the Horizon Europe. Our unit is co-managing Horizon Europe preparations with DG RTD, and combining the research investments for the future, the work we can do on public health actions, and to support to the member states through the Recovery and Resilience Facility, which will be a huge instrument as well. I think we have a better chance of addressing the problems and the challenges that are discussed here today. But it's a little bit difficult to go into details of the content. For example, the EU for Health program is now being negotiated still. It still continues at least next week. And once we start to get an idea what we are talking about in terms of content, I think, of course, we reach out to stakeholders then. I think the stakeholder community in the EU Health Policy Platform, I've just noticed, I think there's like 100 different groups on different areas. So I think it's also a message to the stakeholder community, really to have clear messages, joint objectives, and that we work together towards the common objectives. So it's never been done.
And can I just bring you in, just before I go to Patricia, so the voice of the patient, when we're talking about stakeholders then, the voice of the patient is important, I assume, is it, Mariana?
It's extremely important because, I mean, even though I'm a medical doctor and I've of course been a patient in some way or another, we need to have the sort of, it's not only about views, but really how can we make sure that what there or the actions that they're actually implementable in real life, and to bring also the implementation is a focus for me always. We can talk a lot about politics and what's important, but in reality, a lot of things have been developed. A lot of things are being developed, like this interesting Irish initiative. And what we need to do is to really make sure that things that are planned work in practice, and they're useful for the people who need them.
Patricia, then, what more could be done at the level of patient groups? We have somebody on the Q&A, for instance, saying that it's Neil Johnson. He says that investment is decreasing in pharma investment by pharma in CVD is decreasing relative to, for example, oncology. Not a coincidence that the patient voice is strong in oncology. Well, I mean, would you say, Patricia, that you need to play a greater role? What more can you do?
Well, the biggest stakeholder in this area is the patient. So first of all, you have to get the patient on board, also in policy making. And this is a huge difference from what we're used to. In my objective, when you start the research, you have to involve the patient already in the design phase of the study. We have to think of the patient as an equal partner in this whole area. To get the right people on board, you have to get the patients on board. That is in R&D, that is in all spectra of this stakeholder management. So what the biggest opportunity would be to unite all the patient groups and to have the talkings on policy level with the doctors, the researchers, and those patients. And also think about the outcomes. Now we always have the quality of life indexes and the usual prompts. But are these patient-reported outcome measurements, are they measuring what is important for the patient himself? And that's not always the case. So I really think that we should try to empower the patients to get on this level to be really an equal partner in this stakeholders management.
And yeah, Janneke, from the industry point of view, would that be right? Would our questioner, not what Patricia said, but what the questioner said, that there's more activity on cancer because the voice of the patient group is stronger? I mean, how much are you working with patients, listening to patients, being influenced by patients?
So first of all, of course, I can only speak about Novartis. I can't speak for the whole industry, but of course, our commitment is strong both on oncology and on cardiovascular disease. And also on, I think Patricia makes a great point, on involving patients very early on in the process to make sure that the trials don't just fit the regulator endpoints and the payer endpoints, but also the patient endpoints. I think that the second part of Neil's question in the chat is or provocation maybe, is also interesting, right? Where he says, that payers need to place far greater value on what patients need as opposed to just the hard endpoint of mortality. So that's one of the challenges that we have as an industry, is you have all these different demands, right? You have the regulator, you have the payer, and you have the patient. And mainly today, because of the payer needs, you get into these very long studies that I talked about before. If you need to prove mortality, you need long studies with a lot of patients, and that is a big thing to take on as a pharma company. So for us, as a large pharma company, we can do this, but not every pharma company can take that big risk, invest hundreds of millions into an outcome that is, of course, never certain. The other side of that, though, I think, and what would really help to get more investment into cardiovascular is if we would all together, with everything that everybody's talked about, make sure that when there is a new innovation that really adds value, that uptake is much faster, right? Because that is even more of a problem and even more of a disincentive to industry, that if you compare an uptake of an innovative treatment in cardiovascular disease, it tends to be much, much slower than in many other disease areas, exactly for the reasons that everybody has mentioned, right? Patients are asymptomatic, they're somewhere lost in the system, they may be somewhere stuck in primary care and that connection with secondary care is broken. Or I think David mentioned it before, on the way back, adherence, right, is also very challenging. And all of that leads to, in the end, a very suboptimal use of the medicines that are already available. And that is probably even more of a disincentive than anything else.
So Panos, where do you see then some solutions to the challenges that Janneke was talking about there, in terms of, for instance, the uptake needs to be faster and just finding the patients?
Well, I think, Kathy, that all of our panelists have provided an awful lot of good stimuli for discussion from a healthcare system perspective at this juncture. For example, from Matt, I retained 3 words as he was going on. Patient stratification, population health, and audit. I think David mentioned earlier on the need for healthcare systems to move forward and reform. And Marianne talked about the integrated tools, the different tools that the Commission has in its armamentarium to address chronic disease, not necessarily cardiovascular disease as in name. But broadly speaking, I think there is a perception that we have addressed unmet medical need in cardiovascular disease. This is far from true, of course. Whereas there's equally a perception that we haven't addressed unmet need in cancer, and therefore that misbalance. But from just going back to what Matt was talking about earlier on, I think we probably need to revisit healthcare systems and how they provide care to patients. And of course, the first role of a payer system or a health insurance system is to basically allocate resources wisely. And that effectively means that we need to invest more seriously in prevention, effectively trying to bend, so to speak, the future curve of demand. The second thing is the second role of a healthcare system or a payer system, if you like, is to catalyze new models of provision, effectively in that context of broader healthcare reform. So we're talking there about higher value models that look at better population and patient outcomes at the same or even lower cost, because I think we have that opportunity. We need new funding models for specific interventions. For example, that means health and social care or health impact bonds, for example, that may be that may be available for different types of interventions at different levels, and most likely wider partnerships, including public-private partnerships where these are feasible and possible. And I think we do need to see things not necessarily from a cardiovascular disease perspective, but from a certain subdiagnosis perspective. We need to look at things from a population health standpoint, and population health effectively means looking at an approach aiming to improve the health of an entire population. At the same time, it means improving the health and physical and mental health outcomes, but also reducing healthcare inequality. So I think we have broader perspectives here. Now, in that context, the key components, and I'm going back to Matt's earlier remarks, we're looking at data aggregation. So data is becoming critical. We're looking at patient stratification. So patient stratification and risk in particular stratification becomes critical. We're talking about care coordination. And care coordination relates to both the so-called outliers. In other words, those subdiagnoses where the burden of disease is particularly severe, acute, therefore needs to be addressed with interventions to improve healthcare outcomes. And that takes me back to Janneke's earlier remarks about where there is an opportunity to have a treatment. This needs to become available, but also the inlier focus. So the outlier means those treatments and those subpopulations that are sort of at the edge, so to speak, but also the inlier focus, and that means equity and distributing care equally across jurisdictions. Patient engagement is critical in that context. We're not going to obviously forget the patient participation in this context, and of course performance reporting. In other words, we need to measure what we do, and that takes us into healthcare systems digital health strategies, and we've seen some of that obviously in the UK. We've seen some of that in other European countries, and so on and so forth. So focus on data analytics, therefore, to showcase benefit is going to become absolutely critical.
Let me just, sorry, let me just bring Matt Whitty in here, because a question here is, how will emerging technologies contribute to support effective health delivery across the EU? How emerging technologies, and Panos there talks about the importance of data. What are you seeing in your work, and what possibilities do you see in terms of technologies that could really certainly answer this whole thing about the inequalities of care?
Yeah, I mean, I think it's worth making the point around inequality is that even non-targeted interventions in cardiovascular disease tend to reduce health inequalities. So the more we can target them, the greater benefit we will see, because we know they have a disproportionate impact on patients on health inequalities. In terms of the technologies coming through, I think they're going to be a really key part, and that's both in terms of new treatments coming along that perhaps may be more acceptable to patients or be more effective, but also in terms of diagnostics as well. So in the NHS, we're running a program called the NHS AI in Health and Care Award. So we're looking at ways in which artificial intelligence can also supplement diagnostics, imaging, triaging of patients as well. So we've got an award where we're directly funding technologies right from sort of early stage technologies, which might be at the stage where they need some clinical validation, through prototyping, through to first sort of testing in real world settings, right through to more mature technologies which have been tested and are ready for adoption. So we're looking at how can we implement these safely, and what are the lessons that we learn about how these can be adopted at scale as well. So I think artificial intelligence is one area that is really going to play a big part, and that will clearly link into good data systems, good information sharing between organisations, good understanding of the ethics, understanding of the biases, and linking into broader work that we're working on around the regulation of these technologies as well.
Does anyone else have a thought on technology and the possibilities? Yes, Janneke.
Yeah, I think it would be great to maybe get into a few tangible examples. So I'll give a few that we are involved in that also leverage technology. As we are committed, as I said before, to not only find the right medicines for patients, but also make sure that patients get access faster and stay on treatment. So one very tangible example is a partnership that we have in Germany with Knappschaft, where this is on the adherence side, where actually once patients have the treatment that they need, we have partnered to form a program that involves telemedicine, telecoaching. It involves a clever skill that patients stand on every morning, and they get prompted to answer a few questions, very simple yes or no questions. Then there is an AI engine behind that actually, if there's an outlier of some sort, alerts a nurse who then decides whether an intervention is needed or not. So that's a very tiny example of how we're trying to use technology in partnership with the healthcare system to try and make sure that patients, stay on treatment and actually have proper outcomes. You can also, of course, use technology as was discussed before at the start of the patient journey, right? How can we diagnose patients faster, because many of them are lost in the system. And then there are also still, I think, a lot of interventions that we can do that maybe don't use technology. As an example, since we have, as a company, the great opportunity that we see heart failure clinics and healthcare systems across the whole world, we try to use that advantage that we have by seeing so many clinics to also, for example, help hospitals and in partnership with hospitals, make sure that, let's say, when a patient comes in with heart failure, that patient is optimally seen and efficiently managed by that clinic. A bit similar maybe to what David said in the Irish example with community care. We're also across Europe trying to support hospitals to make sure that their treatment of patients is optimal, and then the connection as well from primary care into the hospital and back again into primary care is well organized, because that's where a lot of patients tend to get lost. So I think there are many examples of either using technology or actually using physical people. Hopefully more technology, right, in the future, because that's much more scalable. But a lot of examples where I see opportunities for what was mentioned earlier, public-private partnerships, where we can all work together to make sure patients get their treatments faster and stay on them.
So Mariana, where do you stand from the Commission's perspective on the need for more public-private partnerships? We've heard from Janneke there, the sort of work they're already doing. But do you think the future has to be, I mean, although you've got a lot more money in the pot for health than you've had before, but do you see that the future is going to be much more working with the private sector?
I can't say that it will be exactly like that, but what I can say that in the for the first time for the EU for Health program, what we as a Commission we proposed was to have a better combination between EU funding programs and to have a blending instrument, which means that, for example, you could start with piloting of new actions from the EU for Health program, or you could do research from the Horizon Europe and then pilot EU for Health program, and then try to do the implementation by using other Commission programs, ESF Plus, or for example, the Recovery and Resilience Facility. And what is new is to link this also to loans. So our bank in the EU is European Investment Bank. So this program, if it goes through as we proposed, would also open up possibilities with the European Investment Bank and with national banks. And European Investment Bank deals with not only with member states, but also with private investors. So I think the link could be coming from there. In terms of public-private partnership, like I understand it, I'm not an expert on that, but I think the future is really where we have this multidisciplinary, we have different funding elements paving the way for some coherent packages, instead of having one individual topic and just one project doing that. I think we have to increase the sort of understanding of what different programs can do for major things to happen. This is something I wanted to say. The other thing I wanted to just, I don't know if I have a chance now, Cassie, there's two questions I spotted from the Q&A.
There certainly was one. Yeah, go and carry on. You answer the questions.
Okay, very quickly, because I think it's quite important. There was a question that how do I know about the evidence for obesity practices or obesity interventions, or in fact, any intervention? Well, personally, I don't follow the science very closely anymore. So what we have done is that we have a system within the steering group on promotion and prevention where we put together experts a few years ago to prepare a list of criteria, what is the best practice. So we had WHO, we had OECD, we had colleagues from different joint actions, we had Joint Research Center, so sort of experts on best practice criteria and evaluation. And those people to put together a list of criteria where you have evidence, transferability of an intervention between countries, cost effectiveness, and so on. And that criteria was discussed by the member states in the strategic platform, the steering group on promotion and prevention. And we used that criteria for any intervention that's submitted through the EU best practice portal. It might sound a little bit rigid and like a long-term, sort of takes a long time to do this kind of process. But the good thing is that whatever comes out of this process is usually, it is good quality, it's validated, and we can propose that to the member states so that it can be transferred across all the EU member states. So the evidence really comes from there. That's one thing. The other thing is, why do I like NCDs and not chronic diseases? Because I think that even if you have had an NCD, it doesn't mean that you will have it for the rest of your life necessarily. For example, with cancer, we try to, I like to think that it's possible to be survivor, and it can be considered that it's over. You don't have to bear that stigma for the rest of your life. So that's why, and also because of the international targets.
Right. Okay. Panos, you wanted to come in, Panos.
Yes, I think. Thank you, Kathy. A useful complement to what Marianne has said is really the Commission's digital health strategy, digital strategy, which also, of course, relates to healthcare. And I think that is one extremely important tool that member states can leverage, obviously, with their own initiatives at member state level. I know we in the UK are leaving the European Union, but we seem to have a digital health strategy in place already. But it also makes me think about tools that we may have available in terms of PPPs that you mentioned earlier on. I was looking at the Office for Life Sciences here in the UK earlier on, and there are a couple of initiatives that were basically signed, so to speak. One related to Genome UK, the future of healthcare, on the 26th of September 2020, and another one much earlier in the beginning of the year, government tackles heart disease with new partnerships. I think these are important considerations to bring to the fore. But since we talked about models of provision, I think it's important to consider alternative ways of funding healthcare. I think David earlier on was talking about primary prevention. I think this is very difficult and very costly, and I think the benefits of primary prevention manifest themselves way into the future. So funding is difficult to find. And one option that might be useful in that context is the so-called health impact bond. In other words, try to bring additional partners into the debate, and with very, very well-defined endpoints. And if these endpoints are met, then obviously there are benefits for patients, there are benefits for the healthcare system, there are benefits for those who put the financing means. But all of that suggests that we may need to have a more targeted approach to cardiovascular disease. David, for example, talked about atherosclerotic cardiovascular disease earlier on. So for those patients, secondary prevention is hugely important. And if we can improve some of their markers, for example, in cholesterol reduction, I think that is an obvious way of improving healthcare outcomes because of the very close link between cholesterol reduction and incidence of and heart episodes, right? So if we want to reduce the long-term burden of cardiovascular disease, then obviously primary prevention plays a significant role. So we need to identify the relevant tools there that would enable us to target patients at risk. And this is where the patient stratification plays a big role. So targeted approaches, therefore, are crucial, number one. Number two, having a data approach that enable us to leverage the information is of strategic importance.
What would you say, David? And then I'll bring Yannick in.
Yeah, thank you. I think technological innovation is so important in terms of secondary and primary prevention. I mean, if COVID-19 had a small silver lining, it would be the acceleration in our delivery of care. No longer a white coat and a stethoscope, but I sat in an office with an electronic medical record and a telephone. And much to my surprise, patients really appreciated this way of delivering care, which was highly dependent upon having that electronic medical record and all the diagnostic information that was necessary in order to advise patients on treatment. And if you think about that change, it is going to become permanent, I think, in the National Health Service. This will be the new way of delivering care, and its applicability in prevention is particularly important because of the complexities of delivering a lifestyle intervention and risk factor management across the board. But all of that can be achieved much more efficiently with these new ways of working. And
Yannick, you wanted to come in there.
Yeah, I wanted to pick up on something that Panel said and then maybe transition to Matt. As Panel, you mentioned an announcement from the NHS earlier this year on how to tackle ASCVD. And that, I think, is alluding to a partnership that we formed with the NHS, and Matt is very much involved in that, so much better positioned than I am to talk about it. But it's an example of something that I think addresses many of the concerns that we've talked about in terms of how fast can the right patients get access to the right treatments. Example of something that I would love to see in more countries, but I'll leave it up to Matt as he is actively involved in this partnership to maybe describe it a bit further.
Matt.
Yeah, so we agreed a commercial deal to accelerate the adoption of a new technology subject to NICE and marketing authorization. And I think the really exciting thing about this kind of deal is that a lot of the time when we're dealing with the apologies for the beeps, my notifications are going off. When we get the a lot of the time, what we're trying to do at the Accelerated Access Collaborative is work through some of the challenges and some of the barriers to adopting innovation. And usually, quite frequently, that is when the technology has been launched. The exciting opportunity here is that actually we're talking about addressing those barriers in advance, so that by the time, and subject to all the approvals, etc., we are ready to go from day one. So we hope to get faster uptake of that as well. But it's just a really innovative way of working, and something that we're looking to do more of through something called the Commercial Medicines Framework, that was actually going to look at more innovative ways that we can transact for medicines. And it's again something that we're looking to see whether this is more applicable to other medical technologies too.
Yeah, that includes that whole patient identification piece that we all spoke about is such a big issue, and it includes the whole, digital way of doing that. So with the real objective to get innovative treatments to patients much faster. So to me, I mean, I'm crossing my fingers that it's going to work, right? We still need to see whether this partnership really makes a dent in cardiovascular mortality in the UK, but that's the ambition. So looking forward to seeing more of those collaborations.
Patricia, what's your view from the patient perspective?
I'm really in favor of the telemedicine. We have really good examples also in the Netherlands. I think this will become the new normal in medicine. Only one thing is still on my mind. We're talking about telemedicines and all, but we still have to find those non-symptomatic cardiovascular gene carriers, or the people who are still invisible. And when you look at cancer, in my patient group, I have a lot of young women who suffered from cancer, were treated, and after 5 to 10 years, they developed heart failure. So you can see that at oncology, but also at diabetes, still there is this huge sea of cardiovascular patients coming over us as a tsunami. And I think the patient groups play a huge role in empowerment, to inform the patients. But there is one big problem. Patient groups are consisting of patients, and there are volunteers. They don't get paid. Where is the structure, the financial structure for patient groups? Because that's the real issue also. We all do it as a patient in our free time, and it costs a lot of time. Sometimes we do it from out of the hospital, but there's a lack in the system of supporting patient groups. No, there's no financial infrastructure for that. And that's also a point it's really important for us.
Does anyone have a thought on that, on how to give some better structure to patient groups? Mariana, from your perspective, you no doubt see a lot of patient groups coming through your office, all with their obviously different disease areas that they want to talk about. Do you have any advice on that, on how
it is complicated? It's complicated. It's been for years and years very complicated. So I mean, there's two parts of this story. First of all, of course, the pharmaceutical or the private industry can support patient groups, but then there is always this potential conflict of interest issue that has to be taken into account. Then in terms of sort of funding at the EU level, this is what you probably want to know more about. So in the previous health program, there were operating grants for NGOs. So we don't really divide patient groups with NGOs. It was like that, and I'm not sure which one has it for the time being, but I think it's European Public Health Association. And then you might want to have a look at what's in the Commission proposal for the EU for Health program. I think that could be quite interesting for everyone, but it's impossible to know if it goes through.
We're sort of coming slowly towards the end, because I want to ask you one final question to all of you to answer just in 30 seconds. So we just left with a final thought. And we started off saying that that cardiovascular disease is not as high on the agenda as many of us would like it to be. What is the one action that needs to be taken? It might be something you've already said, but will really make a difference from your perspective? So maybe I could start with you, Matt, because you're nodding. What would you say? 30 seconds.
Thanks, Andy. So we've got we already know the impact on mortality that this can have, but I think we just need to modify that message to retain the impact, the major numbers that we're talking about in terms of the patient impact, but also update that to take account of COVID and how COVID, how this population is disproportionately affected by COVID, and to keep talking about health inequalities. So to not just focus on the headline number, but also think, what does this mean for health inequalities? What does this mean for patients who are at risk of COVID?
David Wood, what would you say?
Well, I would say political leadership, and we require political leadership to give priority to secondary and primary and, of course, primordial prevention, which we have not touched upon today. And I think in England, there are good examples of that political leadership, which have led to the NHS Health Checks programme, a unique screening programme of adults for cardiovascular risk and diabetes. But without that political leadership, there can be no long-term investment in prevention. And that's what it requires. It requires investment beyond the life cycle of a politician.
Okay, Panos.
Kathy, I'll be very brief. A few words only. Coordinated, targeted care, cleverly delivered.
Great, that's good, excellent. Jannica.
So fantastic short words. So I would probably just add to panels, if we do all of your words as partners with all stakeholders in the system, and we are very much willing to be part of that.
Great. Mariana.
Well, I think it's about synergies in terms of funding. And I think it's about keeping health on the political agenda in the EU. We have a chance now, and nobody should take this for granted. This is for a couple of years, and then there could be new priorities. So we should now act together.
And we have a commission president who is a doctor, so it helps, doesn't it? And the last word to the patient, Patricia, the patient. I'm sure you don't like being called the patient, but the voice of patients.
Yes, I would like to introduce a politician, MAP or somebody, just to come along one day in the life of a patient, of a heart patient, and undergo the patient journey himself. Just see what the burdens are in normal life for a normal patient, like there are so many. And that would be very helpful to really bring the practical problems visible, and not only talking about. And I think this is really great and really useful, but I have this real urge to make them to let everybody see what it really is to have a heart condition and what it's like to be dealing with this every day. So,
well, thank you very much. That's very, very interesting perspective at the end there. Birgit Beger from the European Heart Network is going to come back and join us now. If you want to pop back your camera. You heard there, Birgit, political leadership, coordination, partnerships, synergies. I mean, you know, that it's that sense of togetherness that's needed. What are your thoughts what you've heard this morning?
Absolutely. I think that the words are right. Coordination, different stakeholders who bring their expertise on the table. We need to have that on board in order to find solutions. I very much still hope that the Commission still sees and earmarks funds for cardiovascular disease. Maybe it is only on number 4 as NCD hidden, but I would very much hope, as Patricia also said, that it's a tsunami coming up with COVID in particular, that it gets more of an emergency, and that also more funds are dedicated to prevention, primary and secondary prevention, because overall the OECD says it's only 3%, and this sounds ridiculous that only 3% are spent on prevention. So that we need, and we need to earmark R&D money, as Mariana said, for CVD, and be serious about it in order to make a change. But I think the cooperation under this target EU for Health, we take the responsibility what we can do at EU level, but we see also that we build up from the national level the best practices, work together with WHO Europe in order so all layers are united in enhancing the situation for CVD patients.
Well, thank you very much indeed. Thank you all very much for your thoughts. Thank you for the questions. We got to some of them, not to all of them. If maybe one or two of them, some of our panelists can actually answer you in writing if they can spare a few moments after the event. So thank you all very much. I mean, it's something that we will come back and talk about a lot, but the fact is that health is certainly at European level much more on the agenda than it has been before. We've heard that from Mariana, we know that. Do keep tweeting about it. But for the meantime, thank you very much indeed. Enjoy the rest of the day and see you next time. Goodbye.
Thank you. Bye-bye.
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 Bye.